Okay, Salam alaikum. Thank you guys for coming. My name is Mohamed Ibrahim. I'm an now associate professor in Department of Pediatrics at Kuwait University, and I'm a pediatric cardiologist and electrophysiologist. Okay, practicing in Kuwait. Thank you for the invite, and I understand that the attendees are mainly pediatricians. صح guys? صح دكتور أحمد the attendee mainly pediatricians right مو pediatric cardiologists صح ما سمعتك دكتور أحمد
الغالب جنرال بيدياتريشن في بيدياتريك
okay
كارديولوجيست
okay okay so guys please interrupt me if you have any questions okay 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 so guys so this is again this would be an interactive lecture okay just forget about that QR code. This is the first ECG. So this is a patient of mine, 2.6 kilos, newborn, term, baby, who was largely stable, except for high lactates. And this is his ECG at after birth. And I was wondering if someone could help me interpret that ECG. Don't be shy. Oh, it's not very complicated ECG, but we'll just spend a minute or two for that ECG and then we'll proceed and then we'll come back to it. Anyone, guys? You can also type your response through the chat. Okay. Okay, guys, so one question. What's the baby heart rate? Okay, I see people typing 60. Okay. Thank you, Dr. Ahmed. So the baby heart rate is 60. Okay, excellent. Okay. So any differential diagnosis, Dr. Ahmed? Why do you think his heart rate is only 60? Is that normal for a baby, newborn? Anyone else? Okay, yes. Ahmed, can you speak up instead of typing, if you don't mind? Ahmed, Dr. Ahmed? Oh, okay. Okay, so you are not by yourself. Okay, fair enough. Okay, guys. So everyone agrees that the heart rate is 60? Okay. So we will come back to that ECG. Okay. I would really prefer if people can open their mic and speak up and not be shy, okay? So that we all benefit from that lecture. Please, Yani. Okay, so bradycardic for a baby. So we'll come back to it, okay? Unless anyone else want to say anything else, or should I proceed? Okay, I'll proceed. Okay. Okay, so okay, so as Dr. Ahmed was mentioning, so the baby is bradycardic, okay? And then whenever you have a bradycardia, you have obviously differential diagnoses. So your first differential would be sinus bradycardia, and your other main differential would be a form of heart block, okay? There is another differential which is more complex, blocked atrial ectopy that I would also briefly mention. Okay. Okay, so I will keep moving forward and I'll come back to that ECG. Okay. So any guys, any takers? What do you guys think of this ECG? Is it sinus bradycardia? Is it heart block of some sort, or is it blocked atrial ectopy? Dr. Ahmed cannot speak up because
Uh,
it's
I
Dr.
think,
Fadl.
Assalamu alaikum.
Salam.
I
Sorry.
think there is no, from my brief looking, I don't think there's any relation between the QRS complex and the P wave. So I
Okay.
feel like it's more going with the heart block.
Excellent. Okay. Excellent. Okay. دكتور أحمد عفوا سوري دكتور عبد دكتور منو المدثر دكتور مدثر are you a
Now,
pediatrician or cardiologist?
no, I'm a pediatrician.
Okay, excellent. Okay, good observation. Okay, I'll come back to it again. Okay, okay. And then, so I will. So this is another ECG. Another baby who is a couple of months old with this ECG. So is the baby your first question, or my first question to you guys, is the baby bradycardic? Yes or no? And if yes, then how do you explain the bradycardia for this specific baby? I'll give you a minute. Well, guys, the more interactive you are, the more fun the talk would be. So don't be shy. Okay, I see people typing. Not sinus. Okay, heart rate about 90. Sinus bradycardia. Okay, heart rate around 70, 50. Okay, so definitely bradycardic for age. So then like we said, we need to understand why the baby is bradycardic. We have to explain the bradycardia. And most people are saying, or some people are saying sinus bradycardia. Okay, excellent. So can I ask why is it sinus bradycardia? For example, Dr. Fatima, why do you say sinus bradycardia? Dr. Masoub, I guess. Why do you say sinus bradycardia? Anyone? Okay, so Dr. Ahmed is also saying sinus bradycardia because every QRS is preceded by a P wave. Okay, every QRS preceded by a P wave. Okay, excellent. So there's one-to-one relationship between the P's and the QRSs. صح? Okay. But why specifically sinus? How do you define sinus rhythm? Anyone? So people are saying every P wave, for example, here. You guys see my pointer? Okay. So every P wave, you guys see my pointer, right? Every P wave is preceded by, sorry, is followed by a QRS. Okay. So this is a P wave. Okay. Followed by a QRS. صح? Okay. And then there's another P wave here, followed by a QRS. Okay. So every P wave is followed by QRS. Okay. Okay. Let's see. Okay. There's no PR variation. Okay. Or progression. Okay. But why sinus? So the question is, why is the patient? Okay. So Dr. I'm not sure how to pronounce your name. I'm sorry. Masoub. Masoub. Because you're saying because the P wave is upright in lead. Okay, the P waves are upright in lead 2, I guess this is what you mean. Mohamed, okay. Subhi, sorry. Mohamed Subhi, okay. So upright P wave in leads 1, 2, P wave positive in lead 1, 2 AVF. Okay. Okay, someone is saying heart block. Okay, excellent. Okay. So people are becoming more interactive. Okay, good. So the question is why sinus? Because P wave is upright in lead. Someone said P wave is upright in lead 1, 2, and AVF. Okay, so this is the P wave in lead 2, which is upright. This is the P wave in lead AVF, which is upright. Okay, okay. So So I agree. So this is a baby who's bradycardic, and then it's not heart block because with heart block you should have more P's than QRS's. But in this case, every P is followed by a QRS. So P, QRS, P, QRS, P, QRS, P, QRS, and so forth. Okay. There's no P's that are not conducted. Okay. So, and then why sinus? Like we said, sinus, because the P wave should be in sinus, the P wave should be positive indeed 1, 2, 3 AVF, because again, the sinus node is located at the right upper quadrant of the right atrium, okay, somewhere here, okay? So then the direction of the atrial activation, it starts from the right upper corner, let's say 11 o'clock, okay, and going downwards, okay, towards the AV node and towards the left atrium, okay? So, so it's going towards, like, let's say 4 or 5 p.m. if you want to think of this as in terms of times. So this is 3 p.m., 3 a.m., 6 p.m., 9 p.m. So you're going towards like 4 o'clock. Okay, so you're going this way. Okay, so you're going from the right side of the patient chest to the left side of the patient chest. So you're going towards the left leads, and one example of a left lead is lead 1. Okay, so you're going towards lead 1. So hence the P wave should be positive in lead 1 because the activation is heading towards lead 1. Okay, and then 2, 3 AVF being inferior leads. Again, you're going from up to down, from 11 o'clock to 4 o'clock. So then the P wave is expected to be positive in lead 2, 3 AVF in sinus rhythm. Okay, so in order to figure out whether the patient is in sinus rhythm or not, you want to assess the P wave direction or the P wave axis, and it should be positive in lead 1, 2, 3, and AVF. Okay, guys. So that's an example of a bradycardia in a baby, and it's sinus because P wave axis is normal, and then sinus bradycardia because there's one-to-one relationship between P and the QRSs. Makes sense, guys? These are important concepts that you guys should be aware of. Any questions? Easy, difficult? Feel free to speak up. You don't have to type. But most people are answering correctly, and you guys are I understand most of you guys are pediatricians, so you guys are doing great. Okay. Excellent. Okay. So that's an example of sinus bradycardia in a baby. Okay. This is a baby of mine who has a genetic form of sinus bradycardia. His dad is also bradycardic, and there's a genetic mutation that explains his bradycardia. Okay, which is sinus in origin. Okay, which is not very common, by the way, at least in pediatrics. Okay. Okay, so let's keep going. Okay, so that's ECG number 3. Okay, this is a more difficult one. Okay, so another baby who is bradycardic, yes or no? If yes, then let me know why do you think is the cause of bradycardia for this patient. He's a newborn, and for you guys who are neonatologists, that's a very commonly seen ECG. Okay, especially common in neonatologists or neonatal patients.
block premature beat
Okay,
phase.
good. Who is this? I'm sorry.
Ahmed.
Oh, Dr. Ahmed. Okay, Dr. Ahmed. Okay, good. So, Dr. Ahmed, you're saying there are premature beats, صح?
اه
Okay. Can you point to, you cannot point, but can you tell me where exactly? So this is my pointer. Do you see my pen, right? Yeah.
this is the normal beat.
Okay. Where is the atrial ectopy?
The B after the QRS.
I cannot hear you very well, Doctor.
there is another B wave after each QRS.
Okay, which QRS, like number 1, number 2, number 3, which QRS are you talking about?
Each QRS.
Hmm?
Each one there is a B
Okay.
wave after each.
Hello. Okay, each one. Okay, I see. Okay. So P QRS. You think there's a P here?
Here, no.
No. P QRS. There's a P here?
Here. Yes, no.
This one? Yeah. Okay. دكتور أحمد صوتك بعيد بس I think I'm barely hearing you.
عندي مشكلة.
Yeah. Okay, fair enough. Okay. So this is a P, you agree? صح?
صح.
Okay. So this is another this is a sinus P or صح sinus why sinus because so that P is positive in lead 1 نفس ما قلنا positive in lead 2 positive in lead 3 and positive in ABF. Okay, so probably sinus P wave صح. For sinus P wave QRS, then there's a P that looks different صح, which is here, okay, looks different than your sinus P wave صح. Everyone agree, guys? And then that extra P is not followed by a QRS صح. Okay, people are typing complete. So Fatma saying complete heart block. Okay, Dr. Ahmed, you agree? I guess you disagree. Okay. For Dr. Ahmed, are you still agree with me? You're in agreement with me, صح?
I still see that there is before each QRS there is a B wave which is sinus P, and after each QRS there is another B wave.
Yes. Yes. Okay. If a couple of people are saying complete heart block. Okay, but Dr. Ahmed is saying something else. So we're saying there's a P QRS T, P QRS, طبعا sinus P QRS, and then there's an extra P here, not followed by a QRS. But then there's the usual P QRS, and then there's an extra P here. Okay, not followed by QRS, and so forth. Okay, so sinus P QRS extra P, sinus P QRS extra P. Sorry. Okay. زين. Is this complete? You guys still think this is complete heart block? Dr. Fatima, Dr. Saad, you still think this is complete heart block, or you want to change your mind?
I think it's all blocked BECs because there
Okay.
is a fixed BR interval in the يعني normal يعني اللي هي not blocked هي it's fixed BR interval.
Okay. But when you have complete heart block, in other words, you're saying there's no P wave that is able to conduct down to the ventricle. Okay. طبعا how do you explain يعني these PRs are the same. Okay. These PRs are all the same. Okay. So there's some conduction. Okay. For those people who said complete heart block, it is not complete heart block because there are some conduction. Okay. Agree, guys? So these P waves are actually conducting down to the ventricle. Okay. Tamam?
Yes.
But
Yes.
it's not complete heart block. Okay. We have to think otherwise. Okay. So now, but the baby is bradycardic, so you want to explain it. So we said if it's not complete heart block, then other differential would be sinus bradycardia, or there's this differential which I briefly mentioned, the blocked atrial ectopy. Okay. So if you look very carefully, there is a blip. So if you look at this first T wave, okay, PQRS, a clean T wave, okay, but then that T wave looks different, okay, and then this T wave looks different, okay, and then this T wave looks different. So the clean T wave. So this is the PQRS T for that patient. But then sometimes you see there's a blip within that T. And that blip, if you see other leads, you can see other leads, for example, here. So again, PQRS something, and then the T wave. So that something looks like a atrial activation beat or complex, but it looks different than your sinus P, plus it comes in very early. يعني the rate between this P and this P is more than 150 beats per minute, okay? So it's something fast that comes in early that is not followed by a QRS, okay? So these are, if you see, look at B1 for example, P, QRS, بعدين T طبعا, and there's another P here, okay? In other words, these are premature atrial beats that are blocked, okay? This is a very commonly seen in neonates, that the neonate would present as a bradycardia, in bradycardia, because of those blocked ectopy beats, okay? So this is a nice ECG of blocked premature atrial complexes. And when you have a premature atrial, let me clean the screen a little bit. Sorry, just a second. Trace all link on the slide. Okay. So this is a cartoon, or a cartoon of that, of what I'm trying to say. So there's a P QRS T, okay? P QRS premature P. That premature P would would be sensed by the sinus node, and then because there's atrial depolarization, the sinus node would be depolarized through that blocked through that premature complex, and then the sinus node would reset. Okay, so there would not be a sinus beat because there's already atrial activation that already started before the sinus beat, should expect it to come. So the sinus beat resets and waits for a full beat for that patient, and then it will would depolarize. Okay, so those blocked PACs would reset your sinus node, and the baby would present in bradycardia if those premature beats did not actually conduct down the ventricle. If they did conduct down the ventricle, then the baby would present as a tachycardia baby. Okay, so it all depends on how those P waves, the extra P waves, are behaving. If the AV node blocks them, then the baby would be bradycardic, presents in bradycardia. If the AV node is conducting them, then the baby would present like in tachycardia. Okay, makes sense, guys?
Okay.
Might be شوية complex, but I can repeat. Dr. Saad, Dr. Fatima, you understand why it's not complete heart block?
Yes, clear, Dr. Mohammed.
Yeah? Okay. Dr. Fatima? Yes, you said okay. Okay. And then Dr. Maryam was saying focal atrial ectopy. So I guess you mean blocked focal atrial ectopy, which is right, okay? Okay. Next. Okay.
Please, Dr. Mohammed, regarding the treatment, it will be different either it's blocked or not.
Yeah, طبعا if it's not blocked, then the baby would be tachycardic, and then if the baby is symptomatic, then you would treat the baby, and if they are blocked, then the baby would present in bradycardia, and again, if the baby is symptomatic, then you would treat those extra beats. Okay, طبعا usually babies tolerate those extra beats regardless, and we usually just monitor, but sometimes we have to treat. But the treatment is the same. I mean, if you want to inhibit those extra beats, and you want to inhibit them by usually antiarrhythmics. So even if the baby is bradycardic, you want to give an antiarrhythmic medication, which might not make sense to some people, but your goal is to inhibit those extra beats, so that when you inhibit them, then the sinus node would not be reset every other beat, and then the sinus activation would be normal. Okay, but طبعا usually I give flecainide, so because flecainide doesn't affect your sinus rate as much, instead of beta blockers. Okay, so yes, we treat them, but the treatment is the same, but mostly we don't need to treat, we just monitor. واضح?
If the flecainide not available,
Yeah.
we can
مصر
use
ما في-
enteral.
There's no flecainide?
Sometimes not available
Yeah.
in
طبعا
all the hospitals.
yeah, you don't have procainamide, flecainide. I don't think you do, صح? class 1C agent. If you don't
Yes.
have, you can still get beta blocker, بس it might at least temporarily worsen your bradycardia. Okay?
Yes.
Yeah. But I don't know what you guys have in Egypt, you know, I mean, again, most often you don't need to treat, but if you have to, you have to, and then you want to give beta blockers or sotalol or flecainide or amiodarone if need be. But again, very often you don't need to treat. Okay, بس يعني whatever you have to treat with whatever agent you have. And but if you have every agent that is available, that if you have access to every agent, then I would choose flecainide. Okay. Okay.
شكرا دكتور.
طبعا I'm not going to talk about therapies today. We can talk about therapies like next time, because I understand that most people, most attendees are pediatricians, so I don't think therapy is super important. But if you guys are interested in how to treat Brady or tachyarrhythmia patient, then I'm happy to talk about you know, management in a different time. Okay. Okay. Insane. Okay, so like we said, so there's extra atrial activation that is early and with a different morphology. Okay. Okay. زين. So we talked about sinus bradycardia. We showed an example of sinus bradycardia in a baby. We showed an example of blocked atrial ectopy in a baby. Okay. So then we said the other differential would be heart block. Okay. But the heart block, everyone knows that there's first degree, second degree, and third degree heart block. But first degree, do you guys think first degree heart block would present with bradycardia? Yes or no?
Yes.
Yes. So how do you diagnose first degree heart block? Like, what is the ECG finding?
Fixed prolonged BR interval.
Hello. So when the PR is prolonged, will it affect your heart rate?
No, yeah, usually the patient he will be asymptomatic يعني.
لا, I'm not saying about symptomatic or asymptomatic. Heart rate. If you have first degree heart block, would you like, meaning PR is prolonged, would you think the heart rate would be slow, or it doesn't matter? Like a heart rate, should it matter if the PR is yani patient with a PR of 80 milliseconds, for example, and then that same patient PR went up to 200 milliseconds, the heart rate would be the same or different? Same. صح. You still have one-to-one conduction. صح دكتورة هبة؟
Yes, صح. Yes.
صح. Okay,
Yes.
so that's why first degree heart block is not in your differential when a baby or a patient is bradycardic. Okay, طبعا unless you're saying there's sinus node disease plus first degree heart block. Okay, and there's sinus node dysfunction. Okay, but first degree heart block, usually the heart rate is normal for the patient age. Okay, and by the way, first degree heart block there's no block in first degree, because there's one-to-one conduction. It's just PR is prolongation, or conduction time down the AV node is prolonged, but there's no block. So the name is incorrect. Yani it should not be named as as heart block. Okay.
Yes, okay.
مفهوم? Okay. Okay. So okay, excellent. Okay. So now heart block. So when you see bradycardia in a baby and you think it's heart block, you have to decide whether second degree heart block or third degree heart block, and first degree heart block is outside the picture. Okay. 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 انزين. طبعا a hint for heart block is when you see more P's than QRS's, or when you see a pre-R that is prolonged. Okay. انزين. Okay. Questions, guys? انزين. Okay, so this is a patient of mine, infant with congenital heart disease, complex congenital heart disease, with an ECG. This is ECG. Okay, so really quick, is the baby bradycardic? Yes or no? If yes, then what is the reason for the bradycardia for this baby? شوية difficult ECG. So it's okay if you struggle, but don't be shy. I mean, I can help you.
So I can have a try.
Yes.
So I think I can split the ECG to maybe two parts. So there's a part of it that you can see that the PR to the QRS complex, especially in lead 3, if you can see, it is maybe the second. It is there is a like it's almost like 3 boxes, small boxes between the P wave and the QRS, and you can see a deep Q wave as well, and then the second beat, you can see a slight prolongation between the P wave and the QRS, and then so there's some sort of I don't know if this is correct or not, some sort of discordance between the P wave and the QRS, يعني أنا أعتقد إنها more prolonged between the first and the second beat.
Okay.
The third wave, it looks like similar. There is a B wave this time here, but there's no QRS. And then after that you go and you have a similar pattern. So P wave, QRS, and then prolonged P wave, P wave and QRS, and then you have a misbeat.
Okay.
Yeah, so this is
excellent.
yeah.
You're doing very well. Okay.
Okay. So look into it. It could narrow the differential for me. Obviously, this is there's a degree of bradycardia. There's no association. There's some degree of there is a pattern, I would say, and the pattern looks like there is a gradual prolongation between the PR wave, and then you miss the QRS complex. So it looks like a type 2 hard block. Maybe
Like second degree, you mean?
second degree, yes, sorry,
And then second degree is subdivided into type 1 and type 2, huh?
Yeah, yes. That's my interpretation.
So you think it's second degree, is it type 1 or type 2 second degree?
So I think the difference between them is, I think, so for type 2, if it is a type 1, it will be a gradual prolongation of the P wave, PR, and then miss. If in type 2, I think sometimes it can be, معلش لخبط في دي أنا شكلي كده. Say it's type 1, I think.
You're doing great. You're doing great. فصح. فيعني type 1 is gradual PR prolongation, صح? That's what you're
أيوه.
saying, صح?
Yes,
Okay.
yes.
Which is the case here, صح?
Yes,
Okay.
I think so, yeah.
Okay. So you nailed it. Okay. Excellent, دكتور مدثر. طبعا most people in the chat are saying Mobit's type 1. Iman is saying, yeah, Mobit's type 1. Ahmed Subhi, yes. Okay. So everyone is saying Dr. Ahmed Abu Ayad, there is no AB dissociation. Do you, Dr. Ahmed, do you understand now why? I mean, AB dissociation is يعني okay, you're responding? Yes. Okay, got it. Okay, excellent. Okay, so there's no AB dissociation because there is a يعني connection, or there is communication between the A's and the QRS. Okay. Okay. So like what Dr. Mudathir explained nicely, so the PR is gradually prolonging, and then eventually a P does not conduct. Okay, and then the cycle repeats itself. Okay. So this is a nice example of Mobitz 1, which is not a very common يعني bradycardia that we see, at least in pediatrics. And this is one nice example that I do have. These are all my patients, so I'm not يعني Googling ECG images. So I don't have so many examples of Mobitz 1 myself, but this is one nice example that I do have. Okay. Okay, so it's a sinus rhythm, a sinus P wave, of course, because you always have to study the P wave, okay? Because it's positive in lead 1, positive in lead 2, positive in lead 3, and positive in AVF, okay? Okay, so sinus activation with Mobitz 1, okay? Okay, excellent. Okay, let's move forward. We're running out of time. Okay. Sorry, just a second. Okay. So like we said, second degree heart block is divided into Mobitz 1 and Mobitz 2. Okay. طبعا في شيء in between which is 2-to-1 conduction. Okay. And usually when you see 2-to-1 conduction, it's difficult to determine whether the patient is whether that form of heart block is type 1 or type 2, unless you have further ECGs or Holter, and then you see more longer rhythm strips. Okay, then you might be able to figure it out. But if it's only 2-to-1 that you see, just say it's 2-to-1 conduction. You cannot be sure whether it's Mobitz 1 or Mobitz 2. Okay, unless you see more ECGs. Okay. Okay, so that's another patient of mine, complex heart disease with bradycardia. Yes or no? If yes, why is the patient bradycardic?
Second degree heart block, Mobitz type 2 with 2-to-1 ratio.
Okay, say that again, sorry.
Second degree heart block,
Okay,
advanced second degree heart block with 2-to-1 ratio.
okay. So 2-to-1 conduction. Okay.
2-to-1 conduction.
Okay. So there's a P صح؟ QRS صح؟ إنزين.
تمام.
طبعا lead 2 might be difficult. Let's say lead 3. Let's say lead 3. P wave, QRS صح؟ T wave, that's negative here. شفتوها negative. بعدين there's another something that looks exactly like the P wave صح؟
تمام.
Okay. Okay. طبعا that's a hint. Okay. And then if you see like lead 2, P, QRS, T looks flattish, but you know there's a T wave. There must be a T wave after QRS. And there is, whenever you see a QRS complex, there has to be a T wave. Okay. طبعا sometimes the T wave is negative, sometimes flat, so forth. Sometimes difficult to see. But then that blip in the T wave, it looks the same as it. So for example, here you see P wave, and then you see this guy, it looks exactly the same as this guy. And then the patient is bradycardic, so you always have to be suspicious that there's a non-conducted atrial activation. That is the reason for bradycardia. So in this case, there's a P, QRS, P, no QRS, P, QRS, P, no QRS, P, QRS, P, no QRS. And those P that are conducting, they are conduct with a similar PR interval. So there is communication at least every other beat down to the ventricle. Okay. So 2-to-1 conduction, that's an example of a 2-to-1 conduction form of heart block in a baby resulting in bradycardia. Okay. طبعا I know this patient, I have further rhythm strips, and the patient has Mobitz 1 because in other tracings you can see 3-to-2, 4-to-3 conduction, like with gradual PR prolongation. And then there's a hint here because if you see the first beat here, the PR is long and the P blocked, but that PR is shorter. So that's that's a hint. And the QRS is narrow, so that's another hint. But in general, this is 2-to-1 conduction. If you ignore this first beat, this is 2-to-1 conduction ECG. Okay, and you cannot say much further. So 2-to-1 AV block. Again, this is how you determine that ECG is by noticing that the PP intervals are regular, the PR intervals are regular as well or similar. The P is actually sinus in origin. So again, P is positive lead 1, P is positive lead 2, P is positive lead 3, P is positive in AVF. Okay, and there is every other P is dropped. Okay, makes sense? That's a cartoon of that. Okay. Okay. Make sense, guys? Yeah. Easy. Okay. Well done, Dr. Mudathir. Dr. Ahmed Baad. Okay. So, okay. Next. So another patient of mine, complex heart disease, infant with this ECG. If bradycardic, indeed, if you agree it's bradycardia for patient age, I would love for you to let me know why is the patient bradycardic. Guys. You guys can hear me? Yeah? Okay. So suddenly people are quiet. Is this difficult one?
No, I just want to comment on few things.
Yeah.
I don't I think it's tricky for my level, but what I can see is that there is if I will go systematically, I can see a P wave on lead 1, 2, and AVF. So it is sinus. The P wave is coming from
Positive, you mean? Okay.
positive, sorry.
So,
The other thing I can see there is for every 2 P waves, there is a QRS complex.
okay.
And it looks more like a regular pattern.
Okay.
But then the QRS complex by itself, I think they are abnormal. I feel like there are abnormal QRS complex. They are slightly widened.
Yeah.
And
You're a pediatrician or a cardiologist?
no, I'm a pediatrician. I just have
الله.
يعني دكتور أحمد فوزي يعني جزاه الله خير يعني بنحضر معاه وكده فاستفدنا يعني
ابن وين دكتور؟
كده.
السعودية.
أنا شغال الآن في ليدز في يونايتد كيندوم و I have 6 months left for me to complete my training يعني عندي interest في cardiology
بس انت سعودي؟
لا سوداني
سوداني. اوكي.
أيوه.
اوكي excellent دكتور. اوكي. Good luck.
شكرا. Thank you.
انزين.
So
You're doing
that's my
great. Okay.
say it again.
You're doing great.
شكرا يا دكتور شكرا.
Okay.
I think that's my interpretation that there is 2-to-1 P wave to QRS.
Okay.
The QRS itself is abnormal. It could be I don't know if there's if the signal is coming from
Okay,
or
خليك بالكيو ار اس. احنا we're just talking about bradycardia today.
bradycardia. Yeah.
Okay, تمام. انزين.
Yeah.
Excellent. Okay. So look at V1. V1 is nice, by the way. So this is a P wave, okay? QRS, okay? Then this deflection that is within the T wave looks like exactly like a P wave, صح? It's a copy paste, صح? P wave looks funny a little bit because the patient has complex heart disease, but this is a nice example of P QRS, P without QRS, P QRS, P without QRS, okay? في 2-to-1 conduction صح؟ طبعا why not complete heart block? Why do you think it's not complete heart block? Dr. Mudathir or anyone?
Because the BB interval is regular.
It doesn't matter. PP interval could be regular and complete.
مش regular صح. every B followed by QRS.
لا مش every B, every other P.
Every
صح؟
other B, sorry. Every other
It's
B.
how can you tell it's actually يعني PR, look at the PR. The PR is always the same, صح? PR is always the same, صح?
Yes.
with complete heart block, you see PR that's all over the place. But when you see PR that's fixed all over the place, fixed, normal or not normal, fixed, regular, similar throughout the ECG, then you know there's conduction. صح? This P actually went down to the AV node because that PR is the same as this PR, the same as this PR, the same as this PR. So there has to be communication between the P and the QRS because the PR interval are steady. Okay, makes sense? For there is some conduction. That conduction is only happening every other beat. Okay? It's 2-to example of 2-to-1 conduction. Okay, again 2-to-1 form of heart block. Okay? طبعا like Dr. Mudathir is saying, the QRS looks wide for an infant.
البري اكسيتيشن
Sure?
البري اكسيتيشن في دلتا ويف تقريبا.
اوكي دكتور احمد قاعد تكلم انت صح؟ اوكي. You're saying pre-excitation. So with pre-excitation, would you expect 2-to-1 conduction during pre-excitation? With WW or pre-excitation, the conduction is usually 1-to-1, صح?
Yes.
صح. So don't think about
صح.
pre-excitation in the setting of 2-to-1. Okay?
صح. تمام.
I know there's you might imagine delta waves, but remember this is a complex patient, QRS are wide, and furthermore, 2-to-1 conduction, with pre-excitation, you have extra communication between the P and the QRS, between the atria and the ventricle. So it's very, it's very unusual to have 2-to-1 conduction during pre-excitation. Okay? Usually there's more connection.
Okay.
There is 2 pathways to connect down to the ventricle. Okay? تمام? Okay.
تمام.
Okay. انزين. For 2-to-1 conduction هذا موبت 2. Why? طبعا because I know the patient so I can figure it out. But it's a hint for Mobitz 2 type in the QRS is wide. Okay? So you know there's AV node disease or more AV node disease, infra AV nodal disease. Okay? Something something down the AV node that his percutaneous system is diseased. Okay? Okay. Okay. That's a tough ECG. This is not ECG of my, I don't own that patient. He's a patient of, is a patient from Oman. Dr. Ismail from Oman once did send me that ECG for one of his patients. It's an interesting ECG. So we don't have to spend so much time for this, like in this ECG, but it's a newborn. The question is this baby bradycardic, yes or no? If yes, can you help me understand why this specific patient is bradycardic?
If we look at the AVL lead, so the peaked wave is the B wave, and the inverted wave is the T wave. Right?
AVL or AVR قاعد تتكلم؟
AVL and AVF when comparing AVL to AVF.
صح دكتور أحمد excellent. Okay. ما شاء الله you guys are like amazing. Okay, so Dr. Ahmed is saying Ahmed, this is the P wave, صح?
Yes. And this is the QRS.
QRS, صح?
Yes.
This is what?
QRS.
This one.
T.
T.
T wave. Oh, yes. T wave.
This is what?
The B wave.
صح, because it looks like this guy, صح?
Yes.
صح? Okay, so P QRS, بعدين T all the way to here, but there's P before the end of the T wave. So
yes.
What is this? Example of what this is an ECG that is showing what?
Blocked B PCs.
صح, blocked PACs, but مو لا sorry, مو صح. blocked PACs نفس ما قلنا إن PACs إن الاتريال extra ectopy يعني the P wave should look different صح؟ لأن it's coming from elsewhere صح؟ هل P wave
صح.
looks identical صح؟
صح.
either sinus it's sinus to one conduction okay لأن ال P wave is positive in lead 1 2 3 AVF صح؟ والheart rate is appropriate for the baby 120 تقريبا شيء كذي okay فit's a sinus to one conduction. طبعا the question is why is he يعني is it just because there's AV node disease or there's something unusual that explains the bradycardia for this patient? It's not very commonly seen. It's a difficult question, so I can answer that question, but I'll just wait for another second.
It's long QT.
أيوة, prolonged QT. QT is very long, okay? So the QT, I mean, you have to measure it, but it's very long, okay? 600, north of 600, okay? So the QT is very long, okay? So when you have a very long QT, do you understand why the patient might present in 2-to-1 conduction? Or does
because
it?
the second B will come during the recovery period, so it
صح.
will not.
Yeah. So like imagine the ventricle is repolarizing forever, okay? But it's
Okay.
not ready to accept a depolarization wave until later, okay? So when your sinus when your sinus node is or your sinus pacemaker is like going at a rate of 120 130 beats per minute, the ventricle might not accept every other atrial activation, okay? Because of the pathological prolonged repolarization within the ventricles, okay?
Okay.
تمام? So that's an example of 2-to-1 conduction because of prolonged QT interval or QT in a patient with long QT syndrome, okay? طبعا this is a malignant يعني when the patient presents with this long QT interval with 2-to-1 conduction, it's a patient who is at risk of يعني dying, okay? Or يعني risk of يعني the patient is at risk of يعني having torsades or VF or sudden death and so forth, okay? So it's usually a malignant form of long QT syndrome, okay? تمام? Easy guys?
تمام.
Yeah? Everyone else easy? Yeah? Should I repeat something? Okay. Okay, excellent. Okay, so now, so what we said so far that, so with bradycardia, you want to determine whether it's a sinus bradycardia or blocked atrial ectopy or heart block. And then if it's heart block, you have to think of second or third degree heart block. And then if it's second degree heart block, there is it's subdivided to Mobitz 1, Mobitz 2, and 2-to-1 conduction. Okay? Then will Mobitz 2, now we did not talk about Mobitz 2 yet. How do you guys define Mobitz 2? Yani, so with Mobitz 1, there's gradual PR prolongation, okay? With Mobitz 2, there's like, there is yani P blocking without preceding PR prolongation, gradual PR prolongation, okay? And sudden P dropping, okay? Okay, guys? So, okay, so that's one example. So congenital heart disease patient who I don't have so many examples of Mobitz 2, but as you can see, it's not an easy tracing. So there's a P, okay, QRS, T, okay, P, QRS, T, P, QRS, T, P, QRS, T. There's a P here that blocked, okay? زين طبعا the PR, if you measure carefully here, the PR is the same. There's some movement artifact, but trust me, the PR is the same. So that P blocked without preceding gradual PR prolongation, okay? So that's an example of Mobitz 2. مفهوم, guys? Okay? Okay, that's a nicer example. So P QRST, P QRST, P QRST, P blocking without يعني PR gradual PR prolongation preceding. Okay. 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 زين. So now this is not my patient again, but I was just I was like I did see that ECG like in a patient that I inherited this patient from someone else. So that's the ECG of this patient after heart surgery, a patient with complex heart disease. So I'll have to, we have to finish in 5 minutes. I'll just like answer I'll just interpret that ECG for you guys. So obviously there are multiple P's that are not conducting, صح? Okay? صح
Create
guys?
one. تمام.
Yeah, يعني there is multiple P's that are not conducting in between the QRSs, okay? طبعا the P wave axis is abnormal, the patient doesn't have a normal sinus node. So, but let's not worry about that. But this is an example of heart block, advanced or second degree heart block or Mobitz 2 with يعني 3-to-1 conduction
Create
here
one.
and 2-to-1 conduction, okay? Just like يعني higher form of heart block, okay? Not Mobitz 1 and not complete, because if it's complete, so if you know these PR intervals should be different. That PR interval is always the same, okay? This PR interval always is the same. I mean, at least يعني this PR is not exactly the same, to be honest, but these PRs are all the same, okay? يعني if with complete heart block, usually the RR interval is regular or irregular عادة.
irregular أو هي complete heart
لا,
block.
with complete RR interval is regular or irregular?
Regular.
Regular. And you see a
Regular.
regular heart rate, so you know there is some conduction, okay? That's a big hint, okay? Okay. And it's not a complete heart block. There is some conduction, but يعني functionally, you can argue functionally is the same as if the patient is in complete heart block, but technically is the patient not in complete heart block, but he's in an advanced high grade heart block that we usually like manage as if the patient is in complete heart block, okay? إنزين. Okay. إنزين. So now back to the initial ECG. So that's the initial ECG that I did show. So the patient bradycardic, yes or no? If yes, what? Well, I think Dr. Mudethir answered that question. So he said there's complete heart block or AB dissociation, and so these are the QRSs, صح? QRSs. Everyone agrees there's bradycardia for sure, and there are multiple P waves that are coming marching through, and look at the PRs are all over the place. There's no PRs, they are all different, okay? Each PR looks different, okay? The RR interval is regular. There's more P's than QRSs. P's are in sinus in origin, and then the PP interval is usually appropriate for the patient age, which is roughly 150 in this case. It's a newborn, okay? So again, there's regular RR interval, regular PP interval, there's AB dissociation. In other words, irregular PR intervals, P's more than R, there are more P's than QRSs, and the PRs are all over the place, okay? So that's an example of complete heart block. Agree, guys? Okay. For Dr. Ahmed, I think we are done with bradycardia. I was going to talk about bradycardia today, so we're done with Brady arrhythmias. I hope this was this was useful.
Wonderful ما شاء الله محاضرة جميلة روعة تسلم ايد حضرتك.
شكرا. But you guys let me know. I mean, was it difficult, easy for those who were interactive? Mudathir, Hiba, Ahmed, or anyone else?
لا والله شكرا جزيلا يا دكتور محمد، يعني كان very very يعني you take it systematic and step by step and يعني thank you
Okay.
so much. أنا حقيقة استفدت يعني.
Okay, شكرا. Well, good luck for Sudan. شلون السودان؟
والله بس دعواتكم يعني.
يلا
الوضع لسه والحمد لله.
يلا إن شاء
فإن
الله
شاء الله ربنا يهون.
إن شاء الله. um, Okay دكتور أحمد فإن شاء الله it was helpful. فدكتور أحمد you will post it somewhere صح in your YouTube channel صح؟
ان شاء الله. يس ان شاء الله.
Okay. So if you want يعني round 2 I'm happy to do it but you just let me know okay?
اشور we'll be happy ان شاء الله.
We can do
لو حضرتك حابب
we
نصير
can
في
do
اقرب
30
وقت ان شاء
30
الله.
minutes okay?
اوكي ان شاء الله.
Okay. Questions guys? Okay, people are just typing I guess. Okay. يلا شكرا
شكرا.
مع السلامة.
مع السلامه. شكرا لك.